So just no disclosures relevant to this presentation. So I'm going to talk about several things that are important. I don't know if I can be able to talk about everything, but mainly to anatomic and functional imaging, fetal imaging, and then maybe some talk about interventions and interventional echocardiography, knowing that the time is somewhat limited, so I won't probably be able to talk a little bit too much about innovations, though that's always interesting. Really, we know that 2D echo, I don't think I need to say too much about it. It's really continues to be the mainstay of accurate anatomic imaging in pediatric patients with congenital heart disease. And that's even in the face of the fact that there's been so many changes that have occurred and so much new technology. People always get worried is MRI, CT, some of the other imaging technologies, but still I think 2D imaging is still the foundation upon which we do our diagnostic imaging for congenital heart disease. Because of superior imaging resolution, because of superior temporal resolution, it's really useful for neonatal imaging, it's portable, all the things that you already know about, and we make a lot of important decisions based on echo alone, such as for borderline hypoplasia of left-sided structures. We really depend on the measurements that we obtain by echocardiography. Nonetheless, we also know that multimodality imaging has become much more common. That is, and when I say multimodality, I mean imaging that includes CT and cardiac MRI. And in some cases, it is the primary diagnostic modality, for example, with vascular rings. Methods of display include 2D and 3D printing for CT, and we're going to hear more about that in this session as well as in the keynote address tomorrow. Angiography, we don't want to leave that out. Catheterization and angiography are still important roles in selecting conditions. So the real question is, what is the continuing and evolving role of echocardiography for evaluation of congenital heart disease? So when we talk about advanced echo imaging, I mean, I think, again, most people know about 2D imaging. I guess I'll focus a little bit more on 3D and 4D echocardiography for evaluation of 3D for evaluation of complex 3D structures in congenital heart disease. Now, 3D and 4D echocardiography aren't new. They've been around for over a decade, more than that, really. But the question has become is, where does it really provide additive value in addition to 2D imaging, too? And I think these are areas in which I think we're starting to see that it really becomes useful, certainly in our laboratory, where it becomes very useful for evaluation. AV valve assessment, I think people know about, using 4D imaging and 4D color flow Doppler, assessment of ASD and VSD morphology and change in diameters, complex 3D and 4D alpha tract evaluation, particularly in regard to biventricular repair. All of this can be performed real time, and also you can do this as well as assist in interventional procedures. Now, I'm not going to say too much. I just want to just reflect a little bit on the static 3D printed models. And we're talking about 3D printing, and again, a lot of stuff is talking about 3D printing. But there are some challenges to 3D printing, and where I think 3D echo does have some advantages, even though it's not truly a 3D modality. It's entity. It's 2D, where you're trying to do a 3D rendering. First of all, with static 3D printing, of course, there's a lack of high spatial and temporal resolution, which is required to refine intracardiac structures, such as valve, leaflet tissue, and chordae. That's why you don't see those very well with 3D printed images. The other thing, too, is that you really don't have the dynamic. You only have a static model there, too. So you really don't see cardiac motion and physiology. You don't see changes in their cardiac structures and ventricular volume with contraction. Changes in papillary muscle and leaflet shape, and actually the dynamics of the AV valve. Visualization of flow characteristics. You really don't see that with a static 3D image. The costs also of 3D printed models is not only in terms of financial, but also labor. It takes a long time to segment these models and to present something that you can actually use as a model. And that takes time. There's no standardized methodology yet for segmentation printing. I think most people know how to do it and do it well, but it's not like there's one textbook that tells you how to do 3D printing. And it's difficult also with the tissue materials that they have to have human tissue properties with the conventionally used 3D printing materials. I know people are trying to do that more and more. But I think these are some of the challenges of that. So I wanted to show, sorry about that, I just came out of order here too, what we do with 3D echo. And I wanted to show something that was really interesting. This is a patient with a double outlet right ventricle and non-committed VSD, interrupted arch, and a small the VSD itself was small. But I want to see what you can see with this. This is the VSD over here. And I want you to see how dynamic it is. Look how it opens and closes. When it contracts, it's probably about 50% of the area of when it isn't diastole too. You wouldn't get that with a static 3D printed model. And this was really important because actually when the surgeon evaluated this and did the repair, they actually had to resect a lot of muscle there, because of the fact that it really looked like it was contracting quite a bit. The other thing that's nice about this is that we can rotate this around and we can crop a number of ways. This is a patient who had a non-committed VSD. This is the pulmonary valve. The aortic valve's over here. The surgeon could have gone to either valve. He decided to go to the aortic valve. I don't have the aortic arch here too. But I thought what this model was really useful for was to show how you can visualize. There's the two AV valves over here. There's two semilunar valves here. There's the VSD over here. And again, to show you the pathway, how you can look at that, and also the dynamic nature of that VSD. This we know with AV valves, and this is a patient, not so much mitral valve prolapse, but with kind of a foreshortened A1, A2 segment of the mitral valve, and you can see it's not coming together real well. And we can clearly see there's severe regurgitation, but the question is, where is the extent of this? Our surgeons now like us to do a lot of 3D in these patients, just so that we can kind of look at the valve and fosse, and not only look at it just with 2D, which is pretty good here too, but actually take a 3D image here too. This is actually looking at an fosse, and these views are somewhat standardized now, in which you actually look at it from kind of the left atrial surface. That's the left atrium. That's the aortic valve over here, and you can see how this A1, A2 segment is not really coapting well, and you have a very broad jet here. And I think this is something that you really don't get from a static model too, is you can really see how this the regurgitation occurs. And this is really important because, again, you really need to know how that valve motion occurs, and you can only see that with dynamic imaging. This is a patient with a heterotaxy, and I wanted to show this because this is a very interesting comparison between 3D imaging as well as 3D printing. We actually printed this heart. This is a heterotaxy patient, asplenia with dextrocardia, common AV canal, the pulmonary veins coming in over here. There's a left-sided SVC. There's a slightly unbalanced AV canal, pulmonary atresia, and the aortic valve coming off of this left-sided right ventricle. And you can kind of see it here. This is actually IVC flow coming in. There's pulmonary veins coming in over here. And you can kind of see over here that with 2D imaging, there's a little bit of unbalance of the AV canal, but hard to tell for sure, and some of that's just to follow the imaging here with 2D. So, and then this is just sort of showing it. However, when we look for apical 4-chamber view here, there was a question about whether this patient might actually be septatable. And so this is a real question, although we know that heterotaxy patients are usually not septatable. This is one, especially asplenia. This patient, there was a question raised about whether you could actually use this morphologic left ventricle as the systemic ventricle. So we did an MRI on this particular patient, and this is a MRI, this is a white blood imaging here, and you can see that it does appear that the right ventricle is bigger than the left ventricle. The aorta comes off of the right ventricle. It's a right aortic arch over here. You can see the pulmonary veins coming back to the left-sided ventricle. But the thing I wanted to point out here, there's the right aortic arch. The thing that's important to point out in this particular patient is that it's very hard to tell exactly what the AV valve tissue is doing. And that's going to be really important when you're looking for that. See, here you can see it. You kind of tell, but not real super well. And we actually did print this in just a moment. We also measured the volumes, and this was where the MRI was helpful in showing that the RV volume was much greater than the LV volume. Then if we did a 3D echo over here, you could sort of see here that sorry, let's see if this opens up here. You can actually see the AV valve tissue much better. That's the actual common AV canal. There's a VSD component. There's the ASD priming component, the aortic valve coming off of here. And I think what was very useful here is really to see the attachments of the AV valve leaflets and how they really would appear to interfere with a baffling of the left ventricle to the aorta. And not only that, how unbalanced this AV canal was. It's not just the ventricles are different in size, but actually the AV valve itself is unbalanced and significantly favors the right ventricle right over here. And you can kind of see that here too. This also shows the pulmonary venous return as well. I just want to move on over here because in the interest of time. We did print this model over here too, so I'm just going to show some pictures of it. One was, they're blood pool models. This was with hard plastic. This is actually with a more translucent type of a softer plastic over here too. And I think it was helpful to kind of look at what the heart, what the heart looks like here, left ventricle and right ventricle. Again, the LV doesn't look that small, but actually it is, I think, a little bit smaller than that. It's very hard to tell for sure. This is the aorta coming off, the pulmonary veins coming to the left-sided atrium, the IVC coming to the right side atrium. So this patient would have required a little bit of interatrial baffling as well. Then with that softer plastic model, we opened it up to try and take a look. And the thing you see here is this big AV canal over here. So this is the big VSD component. The ASD component would be right around here. Hard to see super well. This is a little bit of that remnant of atrial septum here. And then this is the crest of the septum. But again, the thing that is hard to tell here, and I apologize, this is still a 2D image. It's better if you actually held in your hand. But it's kind of hard to tell exactly where the AV valve is. So this is actually what I try to do is used to basically crop it the same way that you did with this over here, so you can kind of see. And here's the AV valve tissue over here. This is that crest of the septum as we're looking at it over here. And you could kind of see a little bit better about how the AV valves really play an integral role into the whole decision making process of this particular patient. And as we look at a little bit more further in, I think we'll have a few other pictures in just a moment. Sorry, I'm just going to try and speed this up a little bit if I can. Guess I can't here. But what you'll see is that when we look at it on FOSS, that the AV valve really significantly favors the left-sided ventricle. Here it is. Here's the AV valve. Look how it comes mainly into the right ventricle. There's only a little bit to the left side, and actually they're very two closely spaced papilla muscles, and there's the aortic valve. So I think based on this and what we found with this model too, this patient was not taken for a two-ventricle pair, was taken for a single ventricle type repair, just knowing that it would have been very, very difficult to try and septate this heart. So this is another interesting case over here of a patient with, this is actually done in the interventional lab. This is a patient who had VSD, and we'll talk about this tomorrow. A perimembranous VSD that has a little pouch over here. So we didn't do this all by 3D TEE, but I just want to show the utility of 3D TEE here. We're actually doing a retrograde catheter through the aortic valve, going through the aortic valve and then snaring the wire in the LPA, and then bringing it down to the IVC. Again, this was a combination of 2D and 3D imaging too, but just to show you how 3D can actually help quite a bit. And this is real live 3D imaging here. We're actually putting the device in. You can see it kind of being implanted in. Here it is. The sheath was advanced to the wire, the VSC, the wire removed, the device is delivered right over here. And this is, again, with the device in place right here. You can see in that pouch of the VSD with really released, and it looks like it's fairly steady. And there's no evidence of any residual VSD at all, and fairly safe. So you can see you can use both a combination. This is where I think 3D also really helps too. Can 3D, 4D echo be used for 3D printing? Again, I think that other people will touch on this too. People have done studies trying to use 3D, 4D echo for printing. It hasn't been that, at least as I can tell, that useful. There's been mixed results in being able to get the information you need. A few investigators have tried looking at hybrid 3D printing, combining CT MRI with valve data from 3D TEE. Again, that has been very, very preliminary too, so I think overall it's still a work in progress. This is just show you a couple of papers that have been written, one by Laura Olveri over in DC Children's, showing, this is with transthoracic echo, showing the VSD. Again, not a whole lot of valve data from this, and I have to say it is somewhat helpful, but when you actually have it pointed out to you, but if you didn't have it, it'd be hard to tell. This is actually a paper that just came out in JACE, very interesting, where they did 3D TEE and actually modeled the left atrial appendage for the Watchman device. And I thought this was pretty impressive to see how they could do that. Now, this is not a valve. This is an actual cardiac structure itself using a blood pool, and it's actually pretty impressive. And the size is matched pretty well. So I think that certainly 3D TEE has some real potential value there. Okay, let's move on to functional echo imaging for congenital heart disease too, because again, I think the important thing now is I think from an echo standpoint, we've done quite a bit in terms of being able to diagnose. We're very accurate with diagnosing anatomic congenital heart disease. But now I think our next frontier is really to look at the function and try and evaluate function. This is something that's kind of the holy grail, what we all want to do. There are conventional methods of cardiac function of assessment, but now I think we're starting to get more into the realm of cardiomechanics, deformation and strain, torsion and twist, and diastolic function, which we're trying to look at anyway with a number of different methods to evaluate, including left atrial volumetrics and left atrial strain. People are also starting to try and look at AV valve and similar valve dynamics, which I will not get into a lot during this lecture. But I think AV valve assessment, valve annual assessment is going to play an important role, particularly with single ventricle patients, in which we're trying to assess these very abnormal AV valves, their mechanics, and why do some AV valves fail while others don't. I could present some data on that, but again, I don't have much time today. But I think what I wanted to concentrate on was cardiac function, in particular, how do we assess it now and how are we going to assess it going forward? As most of you know, when we're trying to assess these very abnormal misshapen ventricles, there's no whole lot we can do by echocardiography. If it's a left ventricle, maybe we can do some analogs of Simpson's evaluation. Sometimes you can do a little bit of a fractional area change, look at tissue Doppler too. But most of the time, especially with a single right ventricle or with just a single ventricle of indeterminate morphology, it's usually none, mild, moderate, severe type of dysfunction. And I hate to say it, but that's kind of that's all we have right now. That's semi-qualitative. 3D, 4D echocardiography has a role. I think that it's still in its infancy. There is software that's available. It does take time, and it isn't really automated, which would really help if you had automated methods, which may play a role in the future, in which artificial intelligence type software may play a role in the future in being able to automate things a little bit more. Diastolic assessment, we try to use AV valve inflow, tissue Doppler assessment, volumetric assessment, but I have to say diastolic function is a difficult area in which to evaluate by echocardiography. I want to touch a little bit about strain. Strain is something you probably know, you guys have seen. I think that strain is something that is coming into the fore a little bit more, though it's still mainly a research technique. They're looking at displacement. Now, displacement itself, strain basically is just regional shortening. So it's looking at displacement, and essentially it's looking at the percentage of shortening, okay? So it's really a shortening fraction of individual segments of the myocardium. We call that strain or deformation, with negative being shortening and positive being lengthening. And essentially, the technique that a lot of people are using now is speckle tracking, looking at the actual speckles in the myocardium and tracking them over time. These are just kind of inhomogeneities of the echogenicity of the myocardium, and that they tend to stay in place, and you can actually follow these using the software. It's angle independent, but it does require good imaging and frame rates. And there are several different types of shortening. There's so-called longitudinal shortening, which is lengthwise of the fiber. There's circumferential, that is when the heart is kind of in a circular format, and that's also being used. And then there's radial, which is more of a thickening. And what you can do then is actually plot it out. Now most people are using longitudinal strain at this point in time because they found this to be the most reliable. And you can actually get segments of the heart that come out, and then you take this and you lengthen it out to kind of a long strip over here, and you can follow it both by color flow as well as just kind of tracking the actual strain itself. And you can generate essentially a bullseye model using the apical 4, 3, and 2 chamber to get this really nice strain calculation, which we found has been very, very useful in certain types of populations. It isn't, again, something that is widely used clinically, but I think is important because the question is whether it's going to actually be helpful in trying to detect earlier myocardial dysfunction or being more precise in evaluating. This is normal longitudinal strain. This is a strain that's depressed. You can see there's a global longitudinal shortening, strain of only about minus 13%, whereas this is more like minus 20 or 21%. And then this is dissynchrony too. That's the other area where I think it's going to be helpful. As you can see right here, this is synchronous, this is dissynchrony. It's all over the map. You can imagine that this would be very, very good for patients who have significant cardiomyopathy, perhaps ones you're thinking about cardio resynchronization therapy. I think this is a very important area in which I think strain will be very helpful. So I think that overall cardiac strain has advantages because it probably will serve as a way to detect myocardial dysfunction earlier than conventional measures such as shortening fraction and ejection fraction. And also you're able to evaluate segmental wall motion abnormalities to determine dyskinesis in certain types of cardiac diseases such as Kawasaki's. However, it is something, again, that requires high-quality imaging and high frame rates. The evaluation of speckle tracking can be complex. It is somewhat load-dependent still, and it's still relatively new, so there isn't much clinical data yet on congenital heart disease. And there is also inter-vendor variability, that is Philips, GE, probably Toshiba, Hitachi, even maybe if Samsung does their own. They all have different algorithms, and they're not always standardized, and that's one of the major problems. But this, just to give you a flavor of what I think is a potential of a technique such as this. This is, we're looking at hypoplastic left heart syndrome patients. This is from Texas Children's, where they actually did serial echocardiographic studies in patients with hypoplastic left heart syndrome after the Norwood and then the subsequent bidirectional Glenn, looking at traditional RV measurements and strain measurements, with their primary outcome measure being either death, heart transplantation, or persistently greater than moderate RV dysfunction. And at 11 months, they found that 8 patients had reached that outcome that I just listed. And these patients actually had worse strain measurements, although their conventional measures of RV function were non-discriminatory. So if you look at the patients who had events versus the ones who actually were survivors, overall survivors, you can see that the ones who had events post-Norwood had a significantly lower strain compared to the circumferential and global longitudinal strain compared to the patients who actually were all survivors. And the same thing at pre-Glenn and post-Glenn too. So that is, suggesting that strain was a more sensitive evaluation of myocardial function, maybe an earlier detector. I think the other thing that's important with a lot of these measurements, including strain, is that we have to do serial assessment. Conventional echocardiographic parameters are still going to be important. Serial assessment, like I said, will require some, basically using the same machine or the same vendor for the time period, or some type of the same software analysis package. And that there may actually have to be contribution from other imaging modalities such as cardiac MRI or some type of multi-parameters to be able to evaluate cardiac function in these patients. A couple more things I wanted to touch about with a few minutes I have left over here. One is about prenatal imaging itself, and prenatal imaging is something that I just want to touch on. I know a lot of people do prenatal imaging here too. I think what's been impressive about it is how much better we've gotten in teaching the obstetricians and overall the perinatologists to detect congenital heart disease. But in some areas, it used to be it was about 25 to 30%. In some areas of the country now, it's about like 60 to 70%. There's enhanced detection of certain forms of congenital heart disease, colon truncal abnormalities, or aortic arch abnormalities, and it enables better prenatal counseling and prenatal management too. And I think all of that's really important. We can also predict which patients are going to do poorly and try and follow these patients a little bit more, prepare a little bit more. This is a staging system that we use now, and when they get the highest stage, we can actually have them, basically put on PGE and come over to the hospital right away. And that does seem to make a difference in terms of outcomes. Fetal intervention performed using fetal echocardiography. I don't know if anybody does that out here in Asia, but fetal intervention is something that I think is still not sure that it's really going to be effective, but critical aortic stenosis, critical pulmonary stenosis, and atrial septal enlargement with hypoplastic left heart syndrome. These are all areas in which we're trying to do fetal interventions that are only made possible by fetal imaging with a high-resolution echo. And just kind of showing a few things that people are doing with both, this is a dilation of fetal aortic valve here in utero, and also of trying to open up the atrial septum. There are questions regarding the effectiveness. There's about a 10% fetal loss doing these interventions too. And the data isn't quite perfect either. Most patients with the aortic valvuloplasty still progress, or at least 50 to 60% still progress to hypoplastic left heart syndromes. And even the ones that don't still have some problems with LV dysfunction, showing you that you can't necessarily just be a hammer and try and nail it and make hypoplastic left heart syndrome go away. There are clearly some abnormalities of the LV myocardium. Same thing with the opening of the atrial septum. In some patients it does seem to be helpful, but that's only the ones that survive. There is a fairly high wastage rate during the procedure too. So I think the optimal timing is unclear. Ongoing attempts to improve patient selection criteria are ongoing too. So and outcomes are really dependent on postnatal surgical approach too. So there's a lot of things going on. But again, this is an area I think of advanced fetal imaging. And then I'm just going to finish up real quickly with interventional echocardiography too, touching about some of the things. And interventional echo is an area that I talked about last year. I think is an emerging area for what we do as echo people, because of the fact that we actually have to think more like interventionalists. We have to do things quickly, we have to do things in real time, and we have to be able to communicate so quickly with echo. It is portable, we can use this, it's real time, and that's what's helpful about it. There are several types of echocardiographic modalities: transthoracic, transesophageal, and intracardiac echo. MRI, intracardiac MRI, I know is on the horizon, but still I think has ways to go, partly because technology isn't quite there, and partly because there aren't that many MRI-friendly devices out there right now, so that's the problem with it. The interventional echocardiographer, I guess it has to have a different mindset. I learned a lot by working with Frank King, and it really helped me a lot, just thinking more like an interventionalist and really being able to think through the procedure, be prepared for what happened. There's a lot of different interventions going on right now: periventricular VSD closures, hybrid valve therapy, transcatheter. Much of this is being paced by the adults who are doing a lot of stuff by using echo guidance as their primary modality. Because of this, I just want to show this, is because of all this, we actually came up with a paper that just was published in February of 2019 on using TE in all different settings, both in the OR and in the cath lab as well as the ICU too. And we defined a bunch of 28 different views that you can use now to communicate with people. This was a paper we were very proud of being able to publish. It was accepted, by the way, by it was endorsed by a number of different groups, including the Korean Society of Echocardiography, so you know it's got to be good, right? Reviews: we reviewed 2D, 3D, and 4D TE, discussed the use of TE adults, and illustrated with multiple video examples too. And this is just an example of some of the views that we use. I'm not going to show all 28 views, but just kind of give you an idea of that. With that, I think I don't have much time left. I think probably only a few minutes left or something like that. I think we're about done, or is it about time to finish up? Do we have... Do I have 1 or 2 more minutes to just talk about that? Okay. I just want to talk about one thing, too, that's also pretty interesting, too. And I think Dr. Ng is going to talk about this tomorrow, is about PDA interventions. I know in Asia, people have been doing ductal stents for quite a bit longer. We have started doing that more and more now in the United States, really because there have been several really important papers that have come up that have shown that ductal stenting is at least as good, if not better, than conventional BT shunts in a lot of patients. And so I think it's an area that I think is going to be very, very important. And as interventional echocardiography people, although this procedure, ductal stenting, is done mainly by angiography, I think we have to play a much more important role in defining the nature of the duct, the anatomy of the duct, and helping out the interventional echo people, interventional cardiologists. The other thing is ductal occlusion in premature babies. I'm just going to show very quickly the slides over here because I know Frank is going to go over this. But basically, we are putting in, there's a device that has been approved called the Piccolo device that is out now, can be put in patients as small as 700 grams to close PDAs. And this now seems to be the way we're going in terms of closing PDAs in premature babies. And the neonatologists now, before there was some dispute out whether we should close PDAs or not preemies. Now they're going more toward the side of closing, but by closing it by interventional means too. So this is just showing the device over here. It's a very small device. It was just approved by the FDA. These were some of the animal studies that were done. And this is the device was just approved in January of 2019, also known as the Piccolo device here, the ADO2AS. And our job now as echocardiographers is really to evaluate these patients very carefully, look for them, you have to do precise anatomic imaging, and we actually follow these patients in the cath lab or bedside where the procedure is performed, because there is no arterial catheter placed, but there only is a venous catheter placed because of the smallness of the artery. So therefore, we need echo to actually follow these patients, watch the aorta, make sure that the device itself is not impinging on the aorta or on the left pulmonary artery too. So echo plays a very, very important role. This is our other role as an interventional echocardiographers here. And so we've had to develop different views, some of which we already know about, some of which are a little different. Sometimes you have to improvise and actually, for example, image patients from the neck because of the fact that they have a very short neck in some of these premature babies. So there's a lot of interesting things that are going on with that too. And we also have to remember that there's difference in terms of the anatomy of the ductus too. Sometimes it looks kind of conical like this. Sometimes it has more of an elongated appearance, which is usually what we see with usually the ones we see are kind of fetal ones, either F or type C. That was seen in the Piccolo study too. So trying to characterize much more precisely the size of the duct, the length of the duct is very important for the interventionalists, particularly if they're not going to do this in the cath lab. And in fact, Evan Zahn in Cedars was doing a lot of these patients by the bedside with just a portable fluoro. So he needed echo there to really help him deliver the animal. So I think that's really important. So in summary, I think that echo continues to be the foundation, but there are some things that are going on now, and there's more stuff too that I could talk about. I don't have time. 3D echo, fetal imaging, interventional imaging, all these things are very, very important coming in the future. Echo isn't going away. It's going to continue to be a very important part of what we do. And just to give a shout out, if you will, here to Children's Hospital Los Angeles, we just made the honor roll for the best children's, number 5 overall for the best children's hospital in the country, as well as number 4 for cardiology and cardiac surgery. So very proud of that as well. So with that, I thank you very much.